Good day, everybody. Our talk today will be about bleeding in late pregnancy or antepartum hemorrhages. It will be in two parts, each for about half an hour. So we'll continue with the first part of it. The contents of our talk will be definitions, classification of bleeding in late pregnancy, placenta brevia, the lower uterine segment, what do we mean by it? Management of placenta brevia, then placenta brevia accreta and how to manage it, vasa brevia, and placental abruption. So we'll start with the definition. What do we mean by bleeding in late pregnancy? Generally, we say it is bleeding from the genital tract in pregnancy after 24 weeks gestation and before the onset of labor. 24 weeks gestation is an important landmark. Initially, we used to say 28. It came down 28 weeks. It came down to 24 weeks. And in some centers, we expect it to be 20 weeks. That relates to the gestational age at which the fetus can survive outside the uterus. And also before the onset of labor, if it started in labor, then it will be intrapartum, not antepartum hemorrhage. So how do we classify it? Different ways, but an easy way to do that is to say this is coming from the placental side, non-placental side, or unexplained, and the majority are unexplained. We look at the placental side, possible causes, but yet it is unexplained. So when we say placental side, we still classified into three sides from which it could come: either placenta brevia, or abruptio placentae, or abruption, or vasa brevia. And we'll see each one of them. What do we mean by it, and how can we manage it? So let us go non-placental side. Still coming from the genital tract, but not from the placental side. And here it's a group of conditions. First, ectropion. We used to call it cervical erosion. Now it's an ectropion whereby the squamous epithelium, the ectocervix, is replaced by columnar epithelium. And then it looks red and could bleed easily. Carcinoma of the cervix, cervicitis or infection, vaginal infection, cervical polyp, vulvovaginal varices, and then the unexplained. So the list of non-placental side is quite considerable, related mainly to the cervix, infection in it, change in its epithelium, polyps, and thus we have to identify that. So when we come to placenta brevia, what do we mean by placenta brevia? It means the placenta is inserted in the lower part of the uterus. Here you can see this is a normal insertion of the placenta. It's in the upper part of the uterus. But here the placenta is inserted in the lower part of the uterus. And then we will see classification of it. So here this is a normal insertion of the placenta, and here is the abnormal or placental brevia, defined as when part or the entire placenta is implanted in the lower uterine segment. And we'll see in a minute what do we mean by the lower uterine segment. The incidence is about 1 in 200 to 1 in 300. So this picture clearly tells you what's the normal placenta and what's the placenta brevia. The risk factor for placenta brevia are many. Maternal age, over the age of 40, multiparity, multiple pregnancy, when there is deficient endometrium due to the presence or history of, if she had uterine scar, either a previous cesarean section or a myomectomy or a termination of pregnancy, anything that affects the endometrium. If there is infection in the endometrium priorly, endometritis, manual removal of the placenta that still affects the endometrium and could lead to the possibility of placenta previa. Curettage, submucous fibroids, all these are conditions that could be risk factor. Smoking and previous placenta previa, the recurrence here we say is almost 5%. So the maternal age, the parity, multiple pregnancy, conditions affecting the uterine endometrium, and then smoking and previous placenta previa. Nowadays, the incidence of IVF, in vitro fertilization, or assisted reproductive technology are quite common, and the result could be placenta previa, whereby it is implanted in the lower uterine segment. So how do we classify it? We put it into 4 types. Type 1, it is lateral or just lying in the lower uterine segment. This is type 1, you say. Lying in the lower uterine segment is just type 1. Type 2, marginal. Lying in the lower uterine segment but does not reach the internal os. Type 3, partial. Reaches the internal os but does not cover it completely. Reaches, this is the internal os, you can see here. It covers it partially but not fully. Type 4 is complete or central, which covers lies in the internal os, lies in the lower uterine segment, covers the internal os completely, even if it is fully dilated. So it's type 1, type 2, type 3, type 4. That is the clinical classification we used to say. With the advent of ultrasound now, we tend to group them into 2 groups, minor and major. What we say, type 1 and type 2, these are minor placenta previa. Type 3 and 4 are major placenta previa. And this ultrasound classification will help us when we come to the management of placenta previa. Pathophysiology, how does it happen? Generally, we know that in the first and early second trimester, the lower uterine segment is 0.5 to 1 centimeter from the internal os. Ultrasound diagnosis of the placenta previa is that when reaching 0.5 centimeters from the internal os. In the second trimester, approximately 5% of all placentae appear to be so near to the internal os and judged as low-lying. You see, normally in the first and early second trimester, the placenta is low-lying because it's about 0.5 centimeters to 1 centimeter from the internal os as being diagnosed by the ultrasound. So in the second trimester, approximately 5% of all placentae appear to be low-lying or so near to the internal os. As the lower uterine segment develops, it occupies approximately 1/3 of the uterine volume. Because with the growth of the fetus, the uterus grow, the upper segment will stretches, with contract or stretches upwards, the lower uterine segment tends to form, and it will be about 1/3 of the whole uterine volume. So if you do an ultrasound, then some of the placentae, which were early in pregnancy, low-lying, you will find them, they moved up with the lower uterine segment. and that's what we call placental migration. The placenta does not move, but the lower uterine segment in which it was or it is inserted moves up. What is the lower uterine segment? We have three definitions for the lower uterine segment: physiological, anatomical, and metric. Physiological, we say it is that part of the uterus which passively stretches while the upper uterine segment actively contracts and retracts. So the upper uterine segment contracts, the lower uterine segment passively stretches. That is the physiological, and that's what you see in labor. In labor, the upper uterine segment contracts, pulling up the lower uterine segment. It will be thin and it will be stretched, and it will be probably 1/3 of the whole volume of the uterus. Anatomical is that part of the uterus which is below the reflection of the peritoneum from the bladder on the uterus. And that's used in cases of cesarean section, whereby we open the peritoneum and we push the bladder down so that we can reach the lower uterine segment. So that's an anatomical definition. The clinical or metric definition is that part of the uterus which is 6 to 8 centimeters from the internal os. In other words, that part or that area that could be explored by the examining finger. When you do your finger this way, you do a vaginal examination, any part you reach within the lower uterine, within the uterus is a lower uterine segment. And that also could be made use of in ultrasound. So having said this definition, then we see the clinical picture of placenta previa. How does it occur? How does it present? We usually say it's painless, causeless bleeding with warning bleeds. Just to say there is no cause for it. It could occur during the night, for example, when the lady is at home and when she is resting. Very little pain, if any. But they are usually warning bleeds. What do we mean by that? It means that early on, there are some bleeds, either in form of threatened miscarriage or in the early second trimester, where she have repeated bleeds. No myometrial irritation. This leads to no increase in the uterine tone and no tenderness or contractions. Thus, the abdomen will be soft. High head or malpresentation, normal fetal heart, fetal part can easily be felt. So clinically, she will come with painless, causeless bleeding, with probably a history of bleeds before. There will be no irritation. The abdomen will feel soft. Usually, it is a high head if it is cephalic or malpresentation. The fetal heart is felt here, is heard, and the fetal parts are felt. And also, if there is shock or anemia, it corresponds to the blood loss. If the bleeding she had lost is severe, then you are likely to get more of shock. Management. Admit, take the history and examination, the one which you have just mentioned. No pelvic examination. Don't do a vaginal examination at all. Do the necessary investigations, which are, you'd like to see whether she's anemic or not, doing complete blood count. You would like to check the urine in general, if she had any albuminuria or any other abnormality in the urine. You would like to check the blood group and also cross-match blood for her. She will need that. Then the ultimate is the ultrasound. And here we say ultrasound is better to be done transvaginally. So we have an immediate management, as we have said, admit 2 wide-bore cannulae, IV fluids, crystalloids, and then do necessary investigations we have just mentioned, together with blood grouping and cross-matching of blood. This is the immediate. Then after that, you assess for the ultimate management of placenta previa. It could either then be expectant management or active management. Immediate management for both of them. After you did this in the immediate management, then they will decide expectant treatment or active treatment. What do we mean by the expected treatment? Or why should there be an expected treatment? Because in the past, when the lady comes with antepartum hemorrhage, they transfuse her and they deliver her immediately, irrespective of the gestational age. And obviously that led to so many premature baby being born with a lot of complications. So the objective here is to treat and allow the pregnancy to continue till term, till 37 weeks. And then they will decide how to deliver her, not before that. And this is what we call the expectant treatment. So if it is possible if the gestational age is less than 37 weeks. If it is 37 weeks or more, there is no place for expectant management. We just go for the active management. It's possible if she is not in labor. She may come to you before 37 weeks, but in labor. It is possible if bleeding has settled. And the objective of it is to gain maturity for the fetus. So little bleed that has stopped pregnancy before 37 weeks, not in labor, start with the expected treatment. And what it is, the elements of the expectant treatment, keep the patient in bed rest for at least 3 days after the bleeding has settled. Then prepare blood and keep it ready all the time. And this is the important point, that you have to check that this lady had blood prepared for her in the blood bank all the time, because she may start to have a massive bleed at midnight or an odd hour, whereby the bleeding, the blood prepared will save her life. Repeat the hemoglobin and treat the anemia if there is any, because she may have small bleeds. If she's rhesus negative, then give globulin. Better to do Clyhor test for the accurate dose of the gamma globulin. Give corticosteroids if less than 34 weeks. Keep the hospital in bed or discharge her. So the bleeding has settled for more than 3 days. You manage the anemia, you prepare the blood for her. She may need anti-D, she may need corticosteroids. Then you will decide whether to discharge her or keep her in hospital till delivery, depending on the facilities available for her and for you. Is she living near the hospital? Can she come if the bleeding has taken place, has occurred at a sudden point during the night? So many factors you take, and accordingly you will decide. You may keep her till delivery, or you may send her home to come at 37 weeks, or if she felt pain. Ultrasound in late second and early third trimester as the placenta may migrate. يجاتك late second trimester or early third trimester. You do ultrasound, the placenta may have moved, which was earlier on in the lower uterine segment, may have moved up. Also do continue with the expectant treatment for the fetal growth by ultrasound or by physical profile. So like to care for both mother and child. What is the active management? Active management is possible if the gestational age is over 37 weeks. Then there is no point of the expectant management. Already the fetus is mature enough. If there is heavy sustained vaginal bleeding, and that's irrespective of that, you can deliver her. Or if labor starts, she came to you, she's in labor, so you manage accordingly. The active management procedure, what do we mean by it? Here we relate it to before ultrasound and after ultrasound. Before the era of the real-time ultrasound, we do double setup examination in the theater. That's to say, we take her to the theater, we have a team who is scrubbed, ready to proceed for cesarean section if need be, and the anesthetist is there ready to give anesthesia. And then we do examination in the theater. If we find the placenta previa to be to be type 1 or 2 anterior, then we do artificial rupture of the membranes and syntocinon. While if it is type 2 posterior, type 3 and 4, we go for cesarean section. That is before the time of the ultrasound. With the advent of ultrasound, things were made easy. There is no need for examination in the theater because from the start we will know whether it's minor, placenta previa, or major, as we have said by classification by ultrasound, minor or major. Minor type 1 and type 2 anterior, then we do artificial rupture of the membranes and syntocinon. While 2 posterior, 3 and 4, we go for cesarean section. There are special situations of placenta previa. If the fetus is dead or with lethal anomaly, that's to say, if it's being delivered, it won't survive, or already dead. So we used to do in the past what we call Braxton Hicks bipolar podelic version, historical. Willett forceps is historical, just to tell you about it. What we do now, even if the baby is dead, we go for cesarean section and deliver it. So we stop here, and this is the end of our first session, part 1. And in a minute, we'll go for part 2.